discussion to be moderated by Dr. Ajay Kumar and Dr. Anil Motta, please.
So good evening everyone, and today myself Dr. Ajay Gupta and my co-moderator Dr. Anil Motta sir, and today we have the stalwarts of diabetes, Dr. Rajeev Chawla, past RSSDI president, Dr. SV Madhu sir, past ESI president and past RSSDI president, and Sheryl, she's a known dietitian in Bombay. So today we'll be discussing about some practical topics and practical difficulties which we face in our day-to-day practice. So I would like to just run the slides, please. So like we have different variety of patients coming to our OPDs. Some may be diabetes, some may be pre-diabetes, some may be obesity only. Next, please. So my first question to Dr. Rajeev Chawla, sir, like we have different sets of patients coming to our OPDs, and the approach to the treatment of these patients is totally different. So like these are the two patients or two patient profiles which we have. First is a 40-year-old executive who is having an erratic lifestyle. Who is having an erratic lifestyle with a BMI of 32. He's a newly diagnosed diabetes with HbA1c of 7. The ultrasound showed a fatty liver grade 2 and grade 2 to grade 3, having nearly normal liver enzymes, triglyceride 220, non-HDL 120, and having no family history of diabetes. So this is one patient versus a second patient who is a 70-year-old moderately active retired person with a BMI of 35 with the nearly same investigation profiles, having the history of hypertension, CAD and past PTCA, and presently on moderate dose of statins. So like these two profiles seem to be same as per the investigations, but the age is different, the history is different. So sir, do we have any different approaches for treatment for such patients, sir?
My request is that I think this, Dr. Rajeev, a minute.
Yeah, please.
These patients we have chosen from, our clinical practice. Obviously, it's a garden variety of issues. I request both of you to please pitch in because this is a
both are very routine garden variety of patients. But I think the very fact that presentation for both the patients is absolutely different. Patient number 1 is 40-year-old. He is an executive. He has an erratic lifestyle. So he's sort of sedentary or not doing regular amount of exercise. What we discussed, that patient must do at least 150 minutes of vigorous exercise, so he's not able to perform. BMI by Asian criteria is very, very high. It is 32. We know anything more than 27 in Asian or in Indians is obesity. And Professor Madhu already highlighted the importance of that cutoff for obesity management, which has come down. Earlier days we were talking of comorbidities 32.5 and all those things, but now it is clearly anything more than 27 that we need to address the issue of obesity. And third important thing is that this patient is a new onset diabetes. HbA1c is not very high. Obviously for this young patient we will target anything around 6.5 because this is a young onset patient. Now we have enough evidence which has come over last 7 to 10 years that we must hit early and very, very hard, especially in young patient where the risk of hypoglycemia is not there. So in this patient we will target anything around 6.5 so as to cut down or so as to produce a positive metabolic memory for years to come, because now there is evidence that if within 1 year you are able to get down HbA1c close to 6.5, 5 years down the line, risk of microvascular complication is very, very low. In this patient, another important thing is that ultrasound is showing grade 2 to grade 3 fatty liver. Although you are saying that enzymes are normal, there is too much subjectiveness in ultrasound. I'll not take it on simply face value of ultrasound, even if enzymes are normal in this patient, we just learned from Professor Serene, very, very educative lecture, that most important thing in this patient will be doing a fibrosis risk score, either clinically or ideally looking for a fibroscan to find out what is the extent of fatty liver steatosis, whether it is already NASH or it is already at a stage of fibrosis, because then obviously our approach for this patient will absolutely change, although enzymes are normal. And his lipids are bad for him. Triglyceride ideally should be 150, and even non-HDL is also quite high. Surprisingly, this patient does not have history of family history of diabetes. This mic is not working. This patient does not have family history of diabetes, so it is little unusual for someone developing diabetes at the age of 40 with obesity, with fatty liver, uric acid we have not evaluated, lipids are bad. So I think clearly in this patient, I told you target is getting close to 6.5 with drugs which are now fortunately available, which will not induce hypoglycemia. As Professor Serene told us, in this patient, metformin has to be the first line option. Clearly, Indian guidelines, sir and me, we co-authored RSSD ASI guidelines. Metformin for every Indian patient has to be first line option, although endocrine, ACE, ADA and even European Society Cardiology now gives you an option that you may start with SGLT2 or GLP-1 receptor agonist. For Indian evidence, everyone must be on metformin. This patient must have highest tolerable dose of metformin along with statin and an evaluation for a fibroscan or a fibrosis risk score, which is clinically also available these days. It's a tool which can be used, and targeting a strict diet control, what she alluded to, lifestyle modification to cut down on his weight. Because in this patient, BMI seems to be the core problem, which is carrying entire continuum of his diabetes along with dyslipidemia and other cardiovascular risk factor. So strict lifestyle modification and exercise in the first group. Second is a 70-year-old moderately active retired person. Good
Just
thing is,
one,
yeah.
1 minute, Dr. Ajay.
Yeah.
I would put the same question, Dr. Madhu, that this person, would you, from being an Indian, recommend a combination therapy early on rather than metformin alone?
Two things. One, directly answering your question, and there's one other issue that comes up in this. Combination therapy early is the norm now. That doesn't mean you start straight away with combination, you use it early. Early means you give a trial of metformin and lifestyle first. So there's some confusion about people, when they look at guidelines and people say that you use metformin along with lifestyle, it doesn't necessarily mean you do both the things from day one. Because if you do that, the patient's thrust on lifestyle is almost gone. So therefore, it actually means initiate him on lifestyle, make sure that he's already taking his lifestyle seriously and is following that, and don't wait too long before you start metformin. It actually means that. And same thing applies for your early combination. Early combination is definitely the rule these days. Don't wait too long for combination therapy, but at the same time start metformin, let him stabilize for a couple of weeks or 3 weeks, and try combination if nothing is achieved or targets are not achieved. Don't wait indefinitely on metformin.
The only problem is that this fellow has an erratic lifestyle. He will probably default on lifestyle measures, because that we have seen in India that only 30% stick to their lifestyle. So would it make sense? That's why we asked this question. That would it make sense for us?
Before you ask that question, I wanted to focus on one issue. In this particular patient, I think that's where your erratic lifestyle also has to be addressed. This is a clear case where the opportunity for reversal exists. Yes. And therefore, your stress has to be, and if you're able to motivate that individual, that your diabetes can be reversed. If you achieve a significant weight loss, let's say 10% or so, and therefore you need to change your erratic lifestyle, that will definitely work.
So does the combination...
Here, in continuation of what you asked, That is what I said, highest possible tolerable dose of metformin. I said drugs which will not induce hypoglycemia. Those options are, of course, SGLT2 inhibitor versus GLP-1 receptor agonist. But the very fact HbA1c is 7, there is no other guideline internationally which talks of starting with a combination except ACE, which says if it is more than 7.5. So he very rightly said lifestyle modification, adequate trial maybe 3 months, high dose metformin, whatsoever patient can tolerate, give another 3 months, there is no hurry. This patient is not in symptomatic glycosuria or anything that you must start with combination. If still HbA1c remains more than 6.8 or 7, then in this patient you will add either SGLT2 inhibitor or GLP-1 receptor agonist, depending on the affordability, whether patient is keen for injectable or oral, because there is no dire emergency to get control in 3 months' time in this patient.
So the take-home message is from both of you is that in this person, it should be a properly done lifestyle enforcement, as Sheryl said, and that must be followed up motivation, and that has to be followed by metformin. With or without a second drug is a choice of the physician. But yes, lifestyle management, exercise therapy, weight loss, and controlling his diet, and then to be followed a single. Dr. Naresh has a question, please.
He has BMI of 32, so his underlying disease, in addition to diabetes, is obesity. Of course, lifestyle is excellent, but we know that it doesn't work. And there was a debate in ADA, weight-centric versus glucocentric approach. So don't you think that we should target obesity? Once we target obesity, we put him on GLP-1 receptor agonist, we put him on lifestyle modification and everything. We get his BMI down to 27, we get diabetes reversal.
That is,
so if you ask me, I would prefer GLP-1 receptor agonist.
even before metformin?
Yes.
I don't think that Indian evidence is great.
I know.
How many
But
patients are on
so
GLP-1
I'm
receptor
putting a
agonist in
debate-
India?
I'm-
2% patients.
So I'm putting a debate on you.
I think after metformin, I said, after metformin, SGLT2 versus GLP-1 receptor agonist, depending on whether patient can afford an injectable or an oral SEMA, and whether patient is keen for going on injectable GLP-1 receptor agonist. Otherwise, SGLT2, because this patient, other than having obesity and altered enzymes or maybe fatty liver, NASH or whatsoever it is, there is no clear-cut cardiovascular risk factor like
Like the second patient.
like diabetic nephropathy or CKD or reduced ejection fraction to mandate that this patient must start. That's why I gave a reference of European Society of Cardiology. That is the only guideline which says that before metformin you can start. In this patient,
we'll
yeah, true.
Yeah, I think we need to definitely understand that if obesity is a major problem in diabetes, then we have to focus our efforts on the weight. There is no doubt about it, which we normally don't tend to. So in fact, in our hospital, what we do is, we have an obesity clinic and we have a diabetic clinic as well, which we run separately. And all patients whose BMI is more than 27 are shifted to the obesity clinic, all diabetic patients. Because that thrust of management is weight. Glucose management can take place along with the obesity there. And anybody under 27 remains in the diabetic clinic. So I fully agree that you need to focus on the weight in obese diabetics. That doesn't necessarily mean that you don't focus on the lifestyle. It doesn't mean that. It means you have to give lifestyle. I have seen at least in the last 6 months, at least 10 patients who've lost, let's say, 10 to 15 kilograms of weight only on lifestyle. It's not that it doesn't work. It may not work. You have to be open to that possibility. And what do we have as pharmacotherapy? What you're talking is, yes, to control sugars. But these sugars are hardly anything. HbA1c of 7 doesn't require much glucose control at all. You bring down his weight a little bit, that 7 will come down to 6.5.
Dr. Naresh.
This patient may not require any drug actually.
No, Dr. Naresh.
So I just want
Dr.
to...
Naresh.
BMI 27 से ज़्यादा है और कोमॉर्बिडिटी है तो आप ओबेसिटी को ट्रीट करो.
But obesity with lifestyle.
लेकिन ये भी कहा है कि आज के दिन में
लाइफस्टाइल मॉडिफिकेशन
It will work.
As of today, obesity-centric drug which is licensed to be given is only orlistat in India.
but here is-
It can be an off-label use.
Here is a patient who has diabetes.
Yeah, but that diabetes is, that's what I'm trying to say. Diabetes is marginal. So you don't require that many drugs to control the glucose. It's very simple to control the glucose.
I think what we do.
If this
just
patient,
one-
let's
just
say,
one thing.
had a 7.5 or 8 A1C, what you're saying is absolutely correct.
I think
That is what I said in the
just one
beginning.
thing.
If HbA1c was very high, then there was a place for combination, which will be metformin with GLP-1 receptor agonist or metformin and SGLT2.
I think
7
we'll
is
be coming
moment you
to it.
reduce
We'll be
3-4 kg,
just slightly coming to
patient
it.
may not require any drug at all.
So I'll
We'll
just
be coming
add,
to just a few changes in the guidelines, just a few slides down.
I
The
just
next
add,
is-
sir,
Yes, please.
that looking at this case, and this is something that we often get in our clinic, and I feel they're the most motivated people because, you know, there is still hope. And the whole issue is that erratic lifestyle. If we can help address that, because that's the root cause, I think that becomes very important. And if we work as a team, we're definitely going to be able to see good, results with this
I
patient.
think it's very important that this person meets Sheryl first and then meets us. Because we have lost that concept of lifestyle management. That's very important.
And-
That's why we brought this case first.
And second thing, sir, is the approach for this patient and this patient same? Because
No, I
No.
think
so
that
we
is
now
the
come to
reason
this.
we must discuss. This
Yes,
is an
sir.
absolutely different profile.
Yes, sir, please.
Having common investigation or novel or same investigation profile is absolutely different. Here is 70-year male who is active. So in terms of lifestyle modification, you may not be able to do much. Patient still has very high BMI, but most important thing is patient has hypertension with established coronary artery disease. This patient is a very, very clear case. And you have not mentioned HbA1c, but let's presume it is 7.5.
We have written that.
Similar, sir.
Anything
Same-
around 7.
same profile.
Even if it is 7, here it is the fit case that you make a space or place for usage of SGLT2 versus GLP-1 receptor agonist, even if the glycemic control is good, because this patient has already established atherosclerotic cardiovascular disease. So along with metformin, even if you have to reduce metformin to around 1 gram, seeing his age of 70, where EGFR might, even if it is a normal function, it may not be more than 75 or 80. With age, it goes down. So this patient will be the right case for starting SGLT2 or GLP-1 receptor agonist. Of course, he is already active. Lifestyle modification has to continue. Maybe even if it tolerates 10 milligram of MPAG, that will be good enough because CV death reduction has only been demonstrated with empagliflozin. So here, drug therapy is going to be absolutely different.
Chawla, one 70-year-old hypertensive CAD post PTCA.
Yeah.
BMI 35
Yeah.
and age 70 still surviving is commendable actually.
HbA1c target I'm saying is not 6.5.
No, what I'm saying is age 70 with these parameters surviving at age 70 is commendable
but
medical
he's
management.
an active retired person.
No, but what?
Yeah.
No, the
Other
question
than
is
the
that
fact
no,
that he already had one.
How commonly we see this profile actually in our opinion?
no, the question is not that. Question is that we
These are
what
the
we want
real
to
case
highlight.
scenarios which we have talked. Sir. These are the real case scenarios, sir.
This is a
I
very,
think in
very
this
honest.
patient, we don't have complete profile, but I still expect a longevity of 15 years down the line. We must give him the benefit of either SGLT2 inhibitor, if he can tolerate. He seems to be young. I don't think there should be much issues, or ideally a GLP-1 receptor agonist, reducing the dose of metformin in this way.
Dr. Paras,
The
just
aim
to
is-
add
aim
on
is
to this,
no,
sir.
the aim is to bring out that we don't have to look out only at the investigative profile. Look at the patient. And the approach the patient will be different depending upon the age and upon the comorbidities and all that. That was the aim of trying to bring these two patients which have a similar
One
profile.
thing that we are probably not paying attention to is the fatty liver disease. And given that this patient, the first patient, 40-year-old young male diabetic newly detected with a fatty liver, probably he has insulin resistance. Do we want to address the fatty liver disease or not by giving
Sir, last session, luckily that discussion happened. Many times we prefer using pioglitazone. The top gastroenterologist that we are not using it much. He says metformin, lifestyle modification. Maybe in this patient, SGLT2 will or GLP-1 receptor agonist will reduce NASH to some extent. Fibrosis score may come down. There is no place of vitamin E because it is a diabetes patient. In diabetics, you prefer pio over E. In non-diabetics, you use E versus pioglitazone. But well, SGLT2, GLP both are proven to reduce NASH score also. But Sero may be used in this patient because that is a dual PPAR which may help.
Thank you. I think the next question is for Sheryl. Sheryl, this is the ADA ESD consensus that came out in September 23, a few days ago. And they put a lot of importance to the 24-hour physical behavior for type 2 diabetics. That included the 5 S's of sitting, stepping, sleep, sweating, and strengthening. How do you interpret it from the Indian context?
I think each of it is very relevant, especially in today's times. I think it's not working. Sleep definitely. Can you hear me? Audible, right? Yeah. So, I mean, each one of it, I think sitting, though we've already spoken about, as they say, sitting is the new smoking. So we definitely have to encourage our people to get up more. And we tell them that at least between calls, you get up and you can, do your call while you're walking. Clock in the steps. I think today all our phones, everything else. So that it becomes like a motivation for sure. And sleep, I think, is the most, it's something which is not really discussed. And that is the most important thing, especially that we're seeing today, because people have deadlines to meet, or even when they come back home, they want that me time. And then they sit up late, binging on Netflix, and again unhealthy eating, and sleep really late. And they boast of sleeping only for 3 and 4 hours. And I think I always tell them that you can do with it, but your body can't. It is going to take a toll on your body. So I think sleep is something that we should emphasize during our counseling with our patients, that it is really important to try and get that 7 hours of uninterrupted sleep, and we really focus on it.
So the aim of this slide was to tell that we agree with the guidelines and we have to enforce them, as Sheryl said. And the normal circadian rhythm for sleep should be maintained. It is not just sleeping 5 hours or 6 hours. A normal circadian rhythm with a minimum of 6 hours, not more than 8 hours.
Yes,
and a stepping, strengthening, 5 S's, we have to enforce as part of the lifestyle management in our patient. I hope I'm right.
Yes, maybe.
And also she has mentioned in her slides also that it is different. The exercise was 300 minutes.
Yeah, at least that much. But even if they can achieve whatever, at least start somewhere and gradually step it up and enjoy what you're doing. And so definitely you should do, like they go to the market and they say we worked out. They meet so many friends on the way, but that is not really a workout. They need to do something which is dedicated kind of a workout, and strength training is something.
So the take-home message from you, Sheryl, is that we have to follow these 5 S's and follow them with good amount of motivation and enhancement.
Absolutely.
Fine. The final question, sir, to both of you again, is that this again is the EASD, ADA, this statement that came on September 23. We want your opinion that do we accept what has been said, especially about that the efficacy of glucose lowering with high dose and low dose, do you agree with this, with these guidelines?
And in perspective to the Indian scenario with the Indian patients and looking after the Indian socio-economic conditions, sir.
In this there is hardly, metformin, sulfonylureas and pioglitazone seem to be thrown out.
Yeah, so before I answer the question directly, I think the answer actually would be to look at Indian guidelines. We have several Indian guidelines. Instead of looking at EASD and ADA guidelines, I would encourage you to look at ESI, RSSDA guidelines. They will give you the same things worked out for Indian scenarios, and all your questions will be answered. Now, what this latest guidelines adds is only 2 things, which is an important thing, but RSSDA, ESI guidelines considered this 5 years ago. We have a wheel, which I'm going to show. We have a wheel which addresses all this, which people are now realizing and adding today. This was added 5 years ago or 7 years ago by the RSSDA wheel, which later became an ESI RSSDA wheel. So that will answer all the questions. The only thing we need to understand here is that what they're saying in terms of weight, the previous slide, what they're saying in terms of weight is that in a patient who is obese or where weight is a concern or the major concern, your focus has to be weight-centric, not glucose-centric, which we already discussed. And you have options today available. They may be expensive options, at least across the globe. You have options where I showed you in my presentation also, which can achieve about 15% weight loss, and therefore those options are opening up. And therefore if somebody is a diabetic and in whom weight is a major concern, and those drugs are approved for your use for obesity, and they're available and you can afford, those are definitely good options. And I said that tirzepatide is on the horizon. Some trials have already come. it has entered those guidelines, but it could enter other guidelines as well. There is evidence building up that it has good weight reducing effect. But for India at the moment, I think it will not be top priority. Most of us will not be able to afford. It is injectable. People will have their own concerns. However, you can go on to the, let's say, where is this? Weight loss, nowhere it mentioned SGLT2. Yeah, intermediate, it says SGLT2. Anybody's, at least people will accept that. It is not that expensive, but it causes modest weight loss. So you can achieve some kind of weight loss with that, but not as much as with a GLP-1 agonist. So that's one part. That other part talks about the efficacy of the drugs. Again, the RSSDI guidelines mentions in worsening control which are the drugs are most useful. That's something like that, which is the most efficacious drug. And to that you can add, of course, that the newer GLP-1 agonists are among the most efficacious. Of course, insulin always has been and will continue to be among the most efficacious. Now come to the next slide, please, the one that you want to show. Yeah, here the focus again is on cardiovascular disease primarily and CKD. Again, the RSSDI guidelines, which I will just show at the end of this, the wheel shows there are two arms in that wheel, one of which is established CAD, which is what the first ASCVD mentions, and also has significant cardiovascular risk factors. What are the options? In what sequence? Only thing it doesn't mention is the heart failure, and heart failure, everybody is clear. If somebody has heart failure, SGLT2 inhibitors are by far the best drugs to be chosen, there's no doubt. And SGLT2, the evidence is building up about CKD, and that also is shown in that wheel. There's one arm for the CKD. So with this background,
can we go to your
do
slide?
we have,
let
do
me
we
go to
have
the
wheel?
slides, please.
Do we have wheel?
Yeah,
Yes,
brought-
Dr. Madhu.
I
If you-
brought the wheel. So let's show those 3-4 slides.
please
just
show
to
me Dr.
highlight
Madhu's
this
last
point.
floor slides.
You want this first discussed?
No. This is all. We
This is all.
discussed this.
Can I have my slides, please?
Can we have that wheel?
Then I told
And
him.
we are very lucky that the brain,
ABCDFGH approach.
brainchild behind that wheel, both the stalwarts behind that wheel are here with us.
वो slides
So-
दिखाना, please.
The aim of this all is to say that that RSDI had a much better concept and we should
Yes.
still be following the wheel rather than following these guidelines. This was my aim of putting this slide.
I
so
think-
we'll
Can
go
you,
back to the slide.
can you show my presentation where it stopped? I'm showing the older wheel. The latest revisions might have the newer drugs added to that, which is going to be
Good
released
thing is
next
that
month.
even the hierarchy has been fixed almost 7 years ago. It came first time
Go to the-
2015,
go
then
down.
17 and last were 2020. RSSG ASI wheel.
उसी को खोलना
इसी में last
उसी प्रेजेंटेशन खोलना थैंक यू के बाद वाले स्लाइड दिखाइए
Last slide.
मैं बता के आया था ना आपको वही स्लाइड चाहिए प्रेजेंटेशन वही था जो आपने खोला है
So B emphasizes on weight only. A is atherosclerotic cardiovascular age. B, C is CKD. D is duration. E is established atherosclerotic cardiovascular disease.
Go next or
Yes. Now, I think I'll take this opportunity to actually show you the wheel, because that answers most of our clinical scenarios. This is the wheel which we developed in 2015 and has got modified over the years. And in 2020, the RSD ASA together devised this wheel. And the next one probably is going to come anytime. There might be some updates on the latest drugs on that. As you can see, it's called the A, B, C, D, E, F, G, H wheel. At the center is the lifestyle management, which has to be given to all. Metformin to most patients except some patients of CKD, C means CKD. As you can see, A is age. That first case, the second
Patient
case
number
on the first slide was advancing age. So if you look at A, at the most advanced age, only these choices will be there. You will not use any of the sulfonylureas, you will not use insulin as the first drug, it will be the last, but you will start using these. Okay. Then CKD is advancing CKD as you go from center to peripheral. That means if you have none of these factors important, then all drugs are equally can be used. But if you suppose obesity is a major concern, B, where is B? B is BMI. If obesity is the major concern, increasing BMI means as you go to the periphery, is the most obese. So the only choices you are left with from here downwards is SGLT2, GLP-1 agonist, DPP-4 and AGS, which are neutral. So only those four. Others you will not even consider in a BMI of, let's say, 30, 30 plus. If the BMI is not that high, let's say 27, 26, 25, SGLT2, GLP, these four plus PIO and sulfonylureas also can be given. The weight neutral sulfonylureas at that stage can be given. And of course, if the BMI is not a concern at all drugs can be used. So this is how it was devised. And the same thing, established, E is established CVD. So if somebody has heart disease and established heart disease or significant cardiovascular risk factors, SGLT2, GLP-1 again are the best, as is shown here, followed by PIO, and then the others follow only, if they are the major concern. And then you go to finances. That means in India you said we can't afford. So if you can't afford, then only these options are left, cheapest. Regardless of whatever may be available in the basket, if you can't afford, you have to stick to only these three: sulfonylurea, insulin, pioglitazone, cheapest. And then G is the glucose control, glycemic status. That means if you need efficacious drugs, the worse the control, the earlier you choose insulin, GLP-1, sulfonylureas, which are the most effective. That's what that slide was showing on the left, along with the GLP analogs these days. So everything was targeted earlier. And can we go to the next slide? Next slide, please. Now, just show that slide. Isko chhod do, koi baat. Now, this is a similar case scenario when a patient comes with whatever history, like even the case that you showed, how you are supposed to use that wheel. Now, this is the history. Now, go to the next slide. Now, what are the main issues? You have to identify two major concerns in that patient. It could be obesity, it could be CAD, it could be CKD, whatever. The major concerns in a particular patient who comes to your clinic, which dictates the choice of treatment, have to be identified. Like in this case, he's 48-year-old, so not a concern. Businessman, finance, not a concern. 3 years, so long duration of diabetes is not a concern. Aggressive treatment can be given. Main concern is BMI, 32.5, similar to what you showed. ECG is normal, so cardiac is not a concern, creatinine is okay, GFR is okay, so that's not a concern. So the only concern that you've identified, primary concern, which decides the choice is BMI. And therefore, next slide. And therefore, this is the only thing that you will focus on, and BMI is high, so then you will decide to choose from these. Don't think about anything else. Simple. Next slide. We talked about this severe control, so if you have very poor, let's say A1C, choose only from these. If they're not so very high, then you can even use sulfonylureas. Sulfonylureas are very effective agents, mind you. So in India, it's not out. Next slide, the last one. Established CAD, same thing. It's given in those guidelines, but see, same. The options, similar options are coming up. So this is the thing that we need to understand.
I think that way, these guidelines, which started in 2015 and evolved till 2020, and now we are launching 22 guidelines on 7th of October, are much more comprehensive comparing any other international guideline. Because every issue has been identified, a hierarchy of the drug has been fixed in the circle. So if you read this circle, it is very, very, good tool to choose a drug.
I must add that it is without bias.
Pardon?
Without bias, no
without
fear,
bias,
no,
yeah.
no favor, no
and
fear.
good thing is other international guidelines are also, even KDIGO has adopted our circle, and even ESD has gone back on that circle.
True.
So ours was the first, which came first time in
with
2015.
this, I thank Sheryl, Dr. Madhu and Dr. Chawla. It was a wonderful session. I'm sorry that I have been...
And now we are the capital of not only diabetes, but diabetes treatment and diabetes guidelines also, sir.
Thank you.
Thank you.
Thank you very much, and thanks very much.
Please look at Indian guidelines. There are plenty available these days.
Yes, sir.
True, that's...
I thank all our eminent guests, Dr. Madhu sir, Dr. Rajeev Chawla sir, and Sheryl, and Dr. Motta sir. Thank you.